So I think most people understand the benefits of evaluation and why it's important. It's how we can look at the effect of change and improvement, both the unintended and the intended consequences of that. So the way that we would approach evaluation is we are clinically driven. So from the very start, when we're understanding and scoping out the challenges, we have clinical input. We would then have a really MDT approach. So we bring in lots and lots of different specialities in SME that helps us from doing the solutionising right through to the implementation of solutions. So we would start with a scoping exercise and defining exactly what we want to do. We have a lot of methodologies for evaluation. There isn't a one-size-fits-all. And then the thing that I think that we do a bit differently that works really well is triangulating the evidence. So we'll start with an evidence search. We'll design a PICO, which is a clinical query, and we'll get the evidence out. And then what we do is we put an SME team together that takes that evidence for what's happening, marries that up with the data, and then...
So one of the parts of that role is that we do service evaluations working collaboratively with different parts of the NHS. And we are part of a community practice for Prehab to Rehab, which is a model we've been passionately promoting with Macmillan and UK Active and a number of other national organisations, which basically takes the concept of rehab and places it at the very beginning of someone's journey at the point of diagnosis. The main model for Prehab in Greater Manchester focuses on nutrition, exercise and well-being. Some of the more in-depth versions also look at meds optimisation. So people that participated in the Prehab4Cancer service had a reduced length of stay for up to 2 days in comparison to those that weren't part of it. In colorectal alone, we got to a point where for every 1,000 patients that went through the pathway, 179 more patients were able to be seen because of the capacity that was effective. They were reporting, and it was backed up in the clinical outcomes, that they weren't waiting as long on the symptoms they were experiencing. So people weren't waiting to get to a point where an infection had turned into sepsis before they sought help. They were seeking help at the point where there was something not quite right, but they weren't sure what it was. And the main reason for that was because it wasn't a 4-hour barrier of travel to go and just check it out. It was just down the road. Is that there was a reduction in how many A&E attendances and admissions thereafter occurred, and that's partly because people were attending at an earlier stage and being able to be resolved much quicker.